We now move on to the next oration, that is the Albert Einstein oration. May I invite Dr. Asha ma'am, Professor Meredith Hawkins, and Dr. Michael Boyney on stage. Dr. Faria Afsana, Dr. Asha ma'am, and Dr. Meredith Hawkins, can you please be on stage? To provide us with insights to the remarkable life and legacy of the legendary Albert Einstein, I am honored to invite Professor Asha, Head of Department of Endocrinology at Christian Medical College, Vellore.
Good morning, everyone. It's a privilege and an honor to reflect on the profound impact of Albert Einstein, one of the greatest scientific minds in history. Albert Einstein was a German-born theoretical physicist who revolutionized our understanding of space, time, and energy. Born on March 14, 1879 in Germany, he grew up in Munich, where his family ran an electrical equipment business. From a young age, Einstein exhibited a deep curiosity about nature and a remarkable aptitude for mathematics and physics. In 1895, at the age of 16, Einstein moved to Switzerland to complete his secondary education. He then enrolled at the Swiss Federal Polytechnic School in Zurich, graduating in 1900 with a teaching diploma in physics and mathematics. After struggling to find a teaching position, he secured a job as a clerk at the Swiss Patent Office in Bern in 1902. While working at the patent office, Einstein continued to pursue his passion for theoretical physics. In 1905, he published 4 groundbreaking papers, collectively known as the Annus Mirabilis papers, which introduced the special theory of relativity and the famous equation E is equal to mc squared, establishing the equivalence of mass and energy. This discovery laid the theoretical groundwork for nuclear energy, which in turn revolutionized nuclear medicine. Today, nuclear medicine employs radioactive isotopes both for diagnosis and treatment, and without Einstein's groundbreaking work, these life-saving innovations might never have been realized. In 1915, Einstein presented the general theory of relativity, which extended his earlier work to include gravity. His work on the photoelectric effect, which earned him the Nobel Prize in Physics in 1921, was instrumental in shaping the field of quantum mechanics. This understanding became the cornerstone for the development of imaging technologies that have revolutionized modern medicine. Technologies like CT, MRI, though not directly invented by Einstein, are deeply rooted in the quantum and relativistic principles which he pioneered. Another key contribution was Einstein's theory of stimulated emission, which became the basis for the development of lasers, and laser technology is now the cornerstone for modern medicine, ranging from corrective surgeries like LASIK procedures to minimally invasive procedures that reduce recovery times. Lasers have also impacted the treatment of certain cancers, enabling targeted therapies, minimizing damage to surrounding tissues. His concept of Brownian motion, proposed in 1905, elucidated the erratic movement of particles suspended in a fluid, which further led to advancements in cell culture techniques and gave insights into the molecular behavior that enhanced the understanding of cellular processes, protein folding, and enzyme interactions, and subsequently leading to drug development. So these principles are now used to simulate biological systems and design life-saving therapies. Though not a medical scientist, Albert Einstein's work continues to impact medicine profoundly in various ways, and so today let us honor him by embracing the spirit of curiosity and deep observation. Thank you.
Thank you very much, Asha ma'am, for your thoughtful words. Next, it's my privilege to invite Professor Meredith Hawkins to introduce Professor Allan Vaag, the distinguished recipient of this oration.
First of all, thank you to Professor Asha for such a wonderful honor of Albert Einstein, who, and in fact, my institution in New York is proud to bear his name. And it gives me additional great pleasure to be able to introduce the recipient of the next oration, and that is someone who I met here 14 years ago at an ESICON meeting and have been delighted to get to know since. So, we thereby bestow the prestigious Albert Einstein Oration upon Professor Allan Arthur Vaag. Professor Allan Arthur Vaag has dedicated his career to unraveling the causes and pathophysiological and molecular mechanisms underlying type 2 diabetes mellitus and the associated cardiometabolic complications. A board-certified specialist in endocrinology and internal medicine, Professor Vaag serves as Professor of Endocrinology at Lund University in Sweden, while maintaining a long-standing affiliation with Steno Diabetes Center in Copenhagen, Denmark, where much of his groundbreaking work has taken place. Professor Vaag's distinguished academic milestones include the defense of his PhD thesis in 1993 on the role of the glucose fatty acid cycle in humans, followed by his Doctor of Medical Science degree in 1999, where he expanded the understanding of the pathophysiology of type 2 diabetes mellitus. His pioneering research has significantly advanced the understanding of type 2 diabetes mellitus as a multifactorial and multi-organ disease. His groundbreaking study in twins demonstrated the impact of low birth weight on the occurrence of type 2 diabetes, as published in Diabetologia 1997, laying the foundation for the theory that low birth weight has an additive influence on the development of type 2 diabetes, alongside genetic predisposition and postnatal affluent environmental factors. Through his team's groundbreaking work, Professor Vaag has provided compelling evidence that an adverse intrauterine environment not only increases the risk of type 2 diabetes mellitus, but also contributes to a more severe disease course, characterized by earlier diagnosis, less obesity, higher rates of hypertension, and an elevated risk of cardiovascular and renal complications. These findings, published in Diabetologia in papers between 2023 and 2025, underscore the cumulative impact of early life influences, genetic predispositions, and postnatal environmental factors in the progression of type 2 diabetes. Professor Vaag's contributions hold profound implications for improving prediction and prevention of complications in type 2 diabetes through precision medicine. With profound admiration and heartfelt gratitude, we are privileged to honor Professor Allan Arthur Vaag with the prestigious Albert Einstein Oration on this, the 11th day of January, 2025. We celebrate his unwavering dedication to advancing diabetes research, revolutionizing our understanding of type 2 diabetes, and pioneering innovative approaches towards the Barker hypothesis. Congratulations, Professor Vaag.
Thank you, Professor Meredith Hawkins, for your detailed and insightful introduction. As a gesture of our respect and appreciation, I now invite Dr. Faria Afzana, President, Endocrine Society of Bangladesh and President-elect, South Asian Federation of Endocrine Society, to present the ceremonial shawls and plaques to Professor Allan Arthur Vaag. honor to invite Professor Allan Vaag to deliver the oration. We look forward with great anticipation to his inspiring words and the valuable insight he has shared with us.
I have to say I'm totally overwhelmed. I think that many of you have heard about the imposter, syndrome, and this is exactly where I am now. I mean, this is really the greatest honor that I have had in my lifetime career, the word said, and being here. So I'm really touched by this, and I'm sincerely grateful to the organizers and to the audience for coming here today. In particular, I would like to thank Professor Nihal Thomas and Professor Meredith Hawkins for keeping the connections over years despite the distances and much happening in life, and keeping the dedication to physiology. Nihal and I worked together 10, 15 years ago on your PhD thesis, where we already there had this interest of the early environment. We didn't find so much then, and I remember Nihal as a good scientist. You were overly critical towards the hypothesis and had this strong belief that genetics must be maybe even more important. But yet you actually had this, persistence and together with Meredith to say there must be something about it. And these last days where we have kind of nailed the concept of the lean type 2 diabetes being associated with early undernutrition is a reflection of to me, as said many times, the extreme of what we are talking about, the fetal programming and early life programming. How to call that a new disease, how to implement that in the understanding in diabetes care going forward. We had Peter Swartz giving fantastic inputs to that, and we should act rather than just speculate about it, is one of the outcomes that I really appreciate, which is also a breakthrough for some of us who are scientifically like founded and more skeptical to move to action. So thank you for that, to all of you. Where to start and where to end, and thank you also, Nihal, for telling me that I don't have to stick to the 30 minutes. I'll try to do that anyway, because it is a problem going over time. I would also like to thank the previous speakers for setting this fantastic scene for my talk today. Those who have put the program together has done a very great and logical job, because there were some really important, contributions in each of the sessions here, both regarding the impact of preterm delivery and the marasmus talk also from Debbie Thomas and Michael Boyner. Sometimes you don't really realize how important each of your individual contributions are. But in my talk, I'll try to kind of also incorporate some of these findings in the understanding that I have developed over the last 25 years at least, when I've been interested in this area. So again, before I start, I am very honored. I'm overly honored by the kind of tribute of this oration, connecting it to Albert Einstein. I mean, come on, we are quite a lot from each other in intellectual capacity. But I have to say that he's the one of the scientists I admire the utmost in the world, and I had the great privilege of reading his biography, including how he was not treated really well in his younger years. He was a nerd. He didn't, articulate well. He was not considered a good teacher, and that was why he couldn't get a job actually at the Zurich Institute of Technical Sciences, which was a very disappointing thing to him. He eventually, I think after 10 to 15 years research, got a position at this institute, but where he was way above anybody who's ever worked at that institution. So it's a little like Hans Christian Andersen, the tale of the ugly duckling, that becomes a swan. Another connection with Einstein, or thing to mention here, is the way he worked. I really love that, and think, us scientists, should learn from that, because when we're doing our science, we very often chase numbers of publications, impact factors, co-authorships, and all these kind of metrics that kind of boost us in an academic environment. What Albert Einstein did, he was sitting in his small clerk office there near to the to the railway station in Zurich, and he was so fast to do his work on that patent of his he had. So he did that the first 30 minutes in the morning, and after that he started thinking about the atom physics, where he made these seminal papers that you referred to, and he didn't do a single experiment. He wrote these papers that most of them were published in a German journal called the Annalen der Physik. They were kind of 1.5 page long. And then he very briefly nailed, it must be like this and this and this, and this is why. And the last sentence was, I'll leave that to the empirical scientists to determine whether that's right. I love that. And then 100 years later, it turned out that how impactful that was. The final thing about Albert Einstein, some of you may know that he had a close relationship with a very, very famous Danish atom scientist, Niels Bohr, who was one of the few people who was clever enough to be able to talk to Einstein. So they had frequently meetings where Albert Einstein came to Copenhagen. And one of the things that they discussed was kind of the atom molecule structure and whether the electrons around the nucleus, how that was regulated to determine the energy of each of the atoms. And the key question here was that Niels Bohr, he claimed that it was random, stochastic, whether the atoms jumped from one chain to the other, whereas as Albert Einstein answered to that, that God doesn't throw dices. So he was confirmed that sure that it could be randomness in science, but it actually turned out to be the case that Niels Bohr was right. And among these two, Niels Bohr was a true Christian, I have to say, even though he was a leading and also Nobel award-winning scientist. And that takes us back to Christian Medical College to say Christianity is not, in contrast to science, actually the opposite. So I do not, like you, Ranjan Jasnik, have all these philosophical great quotings, but thanks for also mentioning Søren Kierkegaard, another great thinker. And before I start, I'll also pay my deepest respect to you, Ranjan, for the work you've done. I mean, you are one of the very, very few leaders in this field. I know you were very close to David Barker when all of this happened. And sometimes, one person get credited for a whole field. And I think that I'm fine with calling this the Barker hypothesis and Barker field. But I think we should recognize that many people are standing on each other's shoulders here, and you have been, one of the fathers of all this area. So, and that of course makes me even more proud to succeed you here as a speaker and giving an oration. And here I come back to the imposter. This is not, this is not fair, but thanks anyway. Again, the scene has been set very nicely, so I can take the liberty to take it from a quite high level. And my kind of background is I'm a physician. I'm a specialist in endocrinology, as Meredith says, and I kind of got interested in type 2 diabetes many years ago. And so being a clinician and a endocrinologist, my vision in research was to understand why do you get this disease? And how do you treat this disease? And these two questions has kind of followed me over 35 years and taken me on different journeys. But the last 25 years, the journey has been very much focused on the fetal environment, which has not got so much recognition in the Western part of the world over many years. And one reason has been that there has been a revolution in genetics and understanding of genetics behind disease, and we for many years thought that type 2 diabetes was very much a genetic disease, which it probably not is as much as was thought previously, but we are still in the phase where we are discussing very much the role of genetics versus other factors in development of type 2 diabetes. And this is also where I started my career. This simple model here, which Ranjan also alluded to, I think is important to to concede for all of us, because we are talking about a multifactorial disease, type 2 diabetes. We can't just say it's one factor. So I usually divide it into those that are the constitutional primary factors. Here we have the genes and the fetal environment. But on top of that, we have so many precipitating factors that has to do with mostly whatever happens to us after we are born. And all of these factors we call precipitating factors, or the majority are converging into the affluent lifestyle that we have with obesity promotion. So I feel that we're actually talking about three major domains today. And the one domain we're talking about here, and I'm going to review, is the prenatal domain, where I also try to provide arguments that even though there are many exposures, many causes of impaired fetal growth, there seems all to converge through actually the growth per se and an immature organ development on multiple organs. So one criticism towards this area here has been that, oh, you can't just go for low birth weight. That's a strange parameter. There's so many causes, so it's too simple. You need to find the primary cause. Today I'm not so sure about that, because it's a remarkable precise measure, and actually it also captures the preterm dimension that was also discussed here, and rather talking about small for gestational age, there has been a discussion in Lancet over the recent years that we should rather talk about the small vulnerable baby and consider preterm birth in the same category as low birth weight, which was also nicely addressed in this session here. Right, so when people have got overt type 2 diabetes, we know they get hyperglycemia and they get hyperlipidemia, and then you have this vicious cycle of progression of disease. So really to nail this problem, as Ranjan Yasnik also said, we need to understand it earlier for us to be better to prevent. So going back in time to the mid-90s, after David Barker and Hales had published their pioneering work, we were many who did not believe that it cannot be true, that things that happen in fetal life really impacts risk of disease later in life. And I was working on Danish twins, to the Danish Twin Registry, and the whole idea here was to use the twin model to disentangle genetics versus non-genetic factors and their role in diabetes. And I had the privilege to be able to trace a cohort of 28 twins who were discordant for type 2 diabetes. Half of them were monozygotic and half of them were dizygotic. So we asked the question there, if you are, is in a twin pair where you are genetically identical, what is the reason why one of these twins developed diabetes and the other not? And here we looked into a lot of factors, and one of the factors was that we actually used almost 2 years to trace the original birth weight determinations in each twin. And much to our surprise, we came out with a finding of a significantly lower birth weight in those twins who had developed diabetes compared with a non-genetic identical twin. The magnitude was not that big, it was around 300 grams, but it was statistically significant. So from that time point, we pursued that question in a lot of different studies, including different twin studies. And here I'm also very pleased that you, David Phillips, in the audience, because you wrote a very important critique or intellectual challenge against the twin model before we even started that. And the hypothesis or the issue you made aware of is that twins per se are exposed to an adverse individual environment due to their special anatomy and their in fetal life, and also monozygotic twins have a more adverse intrauterine environment compared with dizygotic twins. So we should be very cautious in just using twin heritability estimates to say how much genetics account for a certain disease. And that was a very visionary paper along the line of Albert Einstein, as I told you yesterday, because you didn't have all the data to show that. But I think some of our studies subsequently, together with Pernille Poulsen and Henrik Nielsen in Odense, actually showed that. So today, I think one of the learnings of this journey here has been, well, yes, I mean, examples of studying discordant twins is useful to understand what is non-genetic, but we should be really cautious in kind of determining the genetic risk of a disease from heritability estimates from twins. So another life journey of mine has been to understand this interaction between genetics and the fetal environment, diabetes. And here I've worked with Torben Hansen and Olaf Petersen, who are world-leading geneticists. And each time a new gene has been found in all the GWAS studies, and you can see we started in 2010 when 25 SNPs were known, and today there's more than 1,200 SNPs known that confers susceptibility to type 2 diabetes. And already in 2010, we actually found that 3 or 4 of these genes, the most significant being the ADCY5 and the CDKL1, these were type 2 diabetes genes associated with low birth weight, and therefore these data confirmed the seminal hypothesis by Andrew Hattersley of the fetal insulin hypothesis, namely that a gene that is causing type 2 diabetes, for instance, due to a genetically low insulin secretion, illustrated in his work, Elegant with the MODY2, the glucokinase defect, could be kind of a confounding of this association between low birth weight and type 2 diabetes. So therefore, this question has been extremely important to answer throughout the years. However, having said that, and again, you may say I'm biased, but basically today, we actually cannot see that more than at least 10 of these type 2 diabetes susceptibility genes are also causing low birth weight. And also, when we look at the genetic variants that are causing low birth weight, there's only the known type 2 diabetes genes causing low birth weight among these. So the genetic overlap between low birth weight and risk of type 2 diabetes is not explaining in any significant quantitative manner the association between low birth weight and type 2 diabetes in the Western world. Of course, it may come out with a gene that we don't know today, but I think the likelihood of finding any major birth weight or type 2 diabetes susceptibility genes is probably not very high. So going back to this question, some of you may know, you didn't mention that, I actually had a career break 5 to 10 years ago when I joined AstraZeneca and was heading the early clinical development in a drug company, which was very strange. But I mean, I got headhunted and I had a fantastic journey there. But I also had the privilege to return to academia in my current position and also at Steno. And then when returning to academia and kind of saying, okay, you have not that many years left of your career, so which questions should you actually go for? And I found that as a privilege. I didn't want to spread myself out over a lot of things, but one thing I wanted to know about that was the incidence rate of type 2 diabetes in the Inter-99 cohort, which is a Danish population-based cohort that has contributed a lot to the GWAS studies within diabetes, and where Torben Hansen and Olaf Petersen has collaborated about. It was founded in 1999, and it was based on systematic screening with oral glucose tolerance test of 7,000 people in the outskirts of Copenhagen. So we did a follow-up study on the incidence rate of type 2 diabetes in the Danish population related to birth weight, and here you see the result. We did it via registers that are very well covering in Denmark. You can see the males on the left side and the females on the right side. You see the females have a lower incidence rate of type 2 diabetes compared with males. And here you should know that we have in this study adjusted for sex, prematurity, parity, and gene risk scores for birth weight and type 2 diabetes, as well as family history of diabetes, socioeconomic status, and adult body mass index. So we have kind of taken all the confounders out here, and we have also excluded those people who had type 2 diabetes at baseline. So these are the first true incidence rate of the association between low birth weight and type 2 diabetes in Europeans. Data are out from PIMA Indians. And strikingly, we found a very clearly linear relationship all over the scale between low birth weight and incidence rate of type 2 diabetes that was not explained by genetics. Looking at this data in another way, using the polygenic risk scores for type 2 diabetes, we could divide this population into 3 categories. Those with the lowest genetic risk on the left side, those with the average genetic risk in the middle, and those with the highest genetic risk on the right side. And here you can see the association between birth weight and incidence rate of type 2 diabetes across different BMI levels. So again, covering these 3 major domains, like the fetal, prenatal, and the incidence rate as aging and body mass index, and taking the genetic component in as a base component here. And what you can see that irrespective of your genetic risk of type 2 diabetes, there's a very clear linear relationship between low birth weight and type 2 diabetes. And you also see that for that to happen, you need obesity. Because if you go to the left side and look at individuals with BMI of 25, and you take the obesity component out of the equation, then also the association between low birth weight and type 2 diabetes risk is not completely disappearing, but it's becoming much less. So that kind of illustrates in a different way to me that we are talking about that this low birth weight phenotype has to do with susceptibility to affluent lifestyle. Because if you continue living, at least in this subject here, with low birth weight, we don't see that increased risk in the western part. We definitely see it when you then combine with affluence. And this slide has also, thank you to Dirk, who showed this slide before, because what we have also done over the years is trying to understand what are the pathophysiological mechanisms behind low birth weight and type 2 diabetes in Caucasians. And when I started in type 2 diabetes research, people were fighting about, is it the pancreatic beta cell, is it the liver, is it the muscle that is causing the disease? Today we're not fighting about that. It's very, very clear that we have a multiple organ disease. We have a multifactorial disease, but we also have multiple organ disease. And I think that's extremely important, this focusing to understand. And the major kind of take-home message from this picture here is that there's no other concept than developmental programming and the fetal origins that can provide a conceptual framework to understand one factor that can cause all of these defects, and has actually been shown in different settings to cause these defects. And this is why I've enjoyed hearing all of your talks, including your liver data, Ranjan. Come back to that. We know about muscle development. Adipose tissue is definitely on the stage. Recent data from Meredith and Nihal Thomas shows that the gut incretin hormones are probably also players in this area. We know that people who are born with low birth weight have a lower kidney size and lower number of nephrons. The Baer-Brenner hypothesis suggests this is underlying chronic kidney disease. We have talked about whether that low birth weight and adverse fetal environment has to do with neurocognitive development, which is certainly a factor also relevant to what we are talking about. And we also know that type 2 diabetes patients do have an increased risk of neurocognitive diseases. So it all kind of fits into this picture here. And finally, of course, I shouldn't forget about the pancreas, which is a very central organ, not the least when we are talking about the two-hit hypothesis as presented by David Thomas, and Michael Boyne is also involved in this work here. I really like that because we know that the pancreatic beta cells are continued to be developed up to the age of 10 years. So really when you combine early undernutrition with undernutrition after birth up to 10 years, you predominantly, in my mind, develop this underdevelopment of the pancreas, which then becomes the prominent feature. As we discussed over the last day, that doesn't exclude the other organs also to be kind of defective. Only that these organs probably doesn't matter so much when we're talking about the lean type 2 diabetes associated with either marasmus or early undernutrition, as Meredith and Nihal have shown. Right, so these are some data on liver fat content in low birth weight subjects. One model we have used over the many years is to study low birth weight Caucasians, subjects with a birth weight in the lowest 10% range of a normal population compared with a birth weight in the 50s to 90s birth weight. And this is an example of such a study. These individuals here are 38 years old. All males. It's very important because this is a very clear male phenotype. And they are non-obese. They all have a BMI less than 30. But the average BMI is 27. And here we see that in the low birth weight subjects, which are the red bars, and that age, 38 years, and without any kind of known diseases, coming to our lab, 22 of these subjects, and 5 of them had overt NAFLD, 5 of them. Non-alcoholic fatty liver disease called MASL today. We were very, very surprised about that finding. And then we exposed them to 4 weeks of carbohydrate overfeeding to see whether they were more sensitive to the increase in liver fat, which was, yes, to some extent the case, but basically they had rather the same differences in liver fat before and after this overfeeding. We also studied them after reversibility, healthy lifestyle intervention of 3 months, but that actually didn't remove the difference in elevated hepatic fat in this low birth weight model. Again, the reason why we see it here is, in my mind, because these subjects have a BMI of 27. We didn't see it in the Hal Thomas studies, where in subjects, I think they had a BMI of 19 living in a rural area. So again, for this phenotype to become present, you need the component of some degree of obesity. But also remember here that the control subjects had the same BMI. So it means that the low birth weight subjects are clearly more susceptible to develop these abnormalities with just small increments in BMI. So going back to the role of the different organs, and also talking about epigenetics that so nicely was put on stage by Rhonda and Jasnik, I think that a lot of really exciting findings in epigenetics have been published in this area. However, I just have to say we haven't nailed this completely. We haven't found the one epigenetic marker, or the 2, or the 10 that explains all this. We are, in my mind, scratching the surface. And we have done a lot of epigenetic studies in different tissues, in muscle and adipose tissue. And we have found something. We've done it together with Charlotte Ling, who's one of the world leading epigeneticists in diabetes. But basically, I have to admit that we haven't nailed it. But one clue I just want to mention here is that we believe that if there is major epigenetic changes explaining this, which there must be, we have to look into the stem cells, because the stem cells are kind of the only cells that we know kind of can develop into all the different tissues, also this is where the whole functional machinery is done. And this is an example of the first study we did in adipocyte stem cells, because we think also that adipose tissue is a key organ. And here we looked at the maturity degree of these adipocytes when they were cultured ex vivo for 12 days during standardized conditions. And what we did firstly was we measured leptin, because leptin is a marker, not only a hormone that regulates appetite, but it's also a marker of maturity in these cells. And then we measured leptin in the media where these cells have grown. You see that on the panel C here. And we were very struck by surprise when we found that they had a 50% reduction of leptin in the circulating media here, which also could be associated with reduced gene expression of leptin in the pre-adipocytes, as well as increased DNA methylation of leptin. So that for us was the first example of first clue for us to look in the stem cells, which we are still doing. Also, I don't have to go through all the details in this study. It was also explained by Dr. Jasnik that we do have a lot of different epigenetic mechanisms. We have the non-coding RNAs, not only microRNAs, there's a lot of subtypes of small coding or non-coding RNAs that have enormously impact on epigenetic mechanisms where we are just scratching the surface. We need much larger studies. We need much deeper sequencing of all of these microRNAs to really understand what's going on. We can't just do same studies as we have done in 2 × 20 and then think we can understand everything. But there are some clues, and then the histone modifications also. Right, so in these adipocytes from low birth weight subjects compared with controls, this was actually the first time we did see some significant differences in gene expression after correction for multiple comparisons in relatively low numbers. And we found that there was 506 genes that had significant altered expression in the low birth weight stem cells. But actually these differences disappeared when we grow them ex vivo. So while they matured, these differences were not present anymore. And what was, if we did the bioinformatical analysis to explain what's going on here, you can see all of the pathways that comes out and are mentioned here, relational elongation, cell cycle, and so on. These are all structural processes that has to do with building the structure of the cell. It's not kind of metabolic pathways like lipid oxidation or insulin action that comes out here. That probably comes later, but the epigenetic code is rather to set the functional machinery of the cells, but then when they then develop either in vivo or ex vivo, then these alterations of metabolism come to play, but it's not kind of the epigenetic machinery at that stage that regulates it. That's our hypothesis right now, and this is what we are pursuing. We have also looked for DNA methylation differences in these stem cells, and yes, when we do a principal component analysis, what comes out as the first order effect is birth weight. So there are significant differences in DNA methylations in the stem cells that we don't find in the more mature cells. This is as much as I will go into the epigenetics today. Rather, the last part of my talk, I'll go back to some other studies that we have initiated over the last couple of years, where we are now, because I'm a clinician, asking the question, what does all this mean in the clinic? Today we are talking precision medicine. We want to find subgroups of diabetes. We have discussed that. There's been a lot of proposal. The Swedish clusters are some of the most important. What we lack kind of is clinical consequence, and we also lack that the clusters can be traced or kind of allocated distinctly to some of the major domains or risk factors, etiological causes of type 2 diabetes. So there's a lot of things that needs to be done in precision medicine, but coming from a clinical perspective, for us to take care of all the patients, for 800 million people living with diabetes globally, we just need precision medicine to get the right treatment and care and medicine to the right patient. So here we founded a study in Denmark called the DD2 15 years ago, and it's all newly diagnosed type 2 diabetes patients. Today we have around 12,000 patients, and most of them have been followed by registers in more than 10 years. We have DNA, and now we've got GWAS on it, but we also got birth weight on it. And this is what I'm going to present for you. And here it's very important to mention that these birth weights are all original birth weight determinations. You can't completely rely on self-reported birth weights. We recently looked into the UK Biobank, but where there's also birth weights that are self-reported. And most of the findings I present to you here, yes, we can see that also in the UK Biobank, but absolutely not to that extent as original birth weights. So we need some original and reliable information about this to nail these findings that I'll present to you. So how does low birth weight impact the clinical presentation in the type 2 diabetes patients? And this is what this slide shows. Here we have divided the population into 4 or 3 categories. We have low birth weight, and we define that here just arbitrarily as the lowest quartile, 25%. So it's a significant proportion of the individuals. And then we have normal birth weights. This is between the 25th and the 75th percentile. And then you can see the odds ratio of low birth weight here being associated, being diagnosed before the age of 45 years, and so on. And you can see easily that there's a linear relationship between low birth weight and earlier diagnosis of diabetes in a Western contemporary population. It reminds you actually what we're seeing in Asia. this component. We are also seeing that BMI in the same manner. If you're born with a low birth weight, you are significantly more likely to have a lower BMI at the time of diagnosis, and you're highly significantly less likely to be severely obese. We interpret that as an expression of the low birth weight subjects being more susceptible to obesity. And what we also see if we look at the family history of type 2 diabetes, which is a marker of the genetic contribution in these individuals. I think that is a very cool result, actually, because what we see is that the lower the birth weight, the less genetic predisposition. So those with a lowest birth weight have a higher chance of having serious family members, and conversely, they have a significantly lower chance of having multiple family members with type 2 diabetes. And what does that mean? That is probably an expression of a dilution of the genetic component while you enrich for the low birth weight component. And this is important for us to understand because it suggests to us and support the view that these domains of the genetic and the prenatal, as well as the affluent obesity rate domains, are additive. And this, again, we also find in the UK Biobank. And here you see what continues to surprise me, this extraordinary linear relationship between low birth weight determined 70 years ago in registers, and then what the time of diagnosis in GPs in Denmark. We can discuss maybe why we don't see it U-shaped. I think it's because of the age of the subjects. We didn't have gestational diabetes 70 years ago as a factor that is probably a driver of the association between increased birth weight and type 2 diabetes. Again, you also see the BMI relationship is completely linear. There's no cutoff point here. Right. When we also look at comorbidities, we can see here that those with low birth weight have a higher risk of having systolic blood pressure above 155 millimeter mercury, and they also have a high chance of having multiple antihypertensive drugs. So despite them being leaner and younger at diagnosis, they have more hypertension. We also see when we do a child's comorbidity index, that's an index of a lot of different diseases, including pulmonary diseases, cardiac diseases, even cancer. We can see that those with low birth weight have a higher child's comorbidity. So they're more sick patients when they're diagnosed. Recently, or last year, we did a follow-up on registers on cardiovascular outcome, including cardiovascular mortality. We did this composite endpoint, and we could show, as predicted in our first paper in 23 in this cohort, that yes, if you are born with a low birth weight, you have a significantly increased risk of cardiovascular disease after your diagnosis. And this is important because it tells us that the segment of the prenatal component in the contemporary type 2 diabetes population is associated with more severe disease course. And I think in this week, actually, the next chapter of this paper comes out in Diabetologia, and we looked at incident kidney disease, chronic kidney disease associated with low birth weight. And here we didn't find such a clear signal, but again, it went completely in the same direction, especially if you look at the urinary albumin creatinine ratio trajectory after diagnosis in these three categories. You see the blues are the one with a birth weight below 2,500 grams, and you can see that they have significantly increased risk of chronic kidney disease in that range. And interestingly enough, it's not something they develop during the disease course. It's already present at the diagnosis, telling us that this is an independent readout of the adverse fetal environment. It's not kind of an increased, susceptibility to hypoglycemia. And finally, what just came out yesterday in the Diabetes, Obesity, Metabolism Journal is another paper that is a little different, but actually this is a genetic paper, because here we took the liberty to say, okay, if the prenatal domain associated with low birth weight is associated with a more severe disease course, then let's look at the major type 2 diabetes susceptibility gene of TCF7 that actually the only gene that's previously been associated with microvascular complications. And much to our surprise, or maybe not completely, but I think surprisingly for the geneticist, is that if you have a type 2 diabetes that is dominated by this major type 2 diabetes gene risk, you have a relatively lower risk of cardiovascular outcomes as expressed by MACE, myocardial infarction, and also to some extent chronic kidney disease. At least it's not worse. Right now, together with Rasmi Prasad, who's also here today, we are following up on that and looking at polygenic risk scores for type 2 diabetes. So we take the totality of the genetic component in type 2 diabetes to see whether we can also see that totality of genetic contribution in type 2 diabetes in the same way might also be associated with a less severe disease course. It's simple, but to me it's actually quite important next step in precision medicine. So after this long story, I'm sure I did overtime, Nihal, but thanks for warning me in advance. To conclude, I mean, low birth weight in the 1999 cohort is associated with increased type 2 diabetes prevalence and incidence rate, and this seems to be additive to the degree of genetic predisposition and obesity. Low birth weight is associated with earlier onset, less obesity, less family history of diabetes, but more hypertension and comorbidity, including CVD, and also chronic kidney disease after the diagnosis. And again, I think many hypotheses has been addressing or trying to capture the concept of the fetal dimension. And as I think we talked about yesterday around Janice, I don't think there's any kind of name to it that has nailed it better than what Barker and Hales came out. I know you had a finger or something to play, you were involved in that discussion, and maybe you gave them that idea. And I think it's still kind of the most accurate in my mind conceptual framework to understand this. This is also means I'm only a humble servant here conveying, the follow-up data of what the Einstein people predicted many years ago. And also it tells you that epigenetic mechanisms, which I certainly think they are there and I must explain it, but I think the stem cells is a way to look. And finally, common type 2 diabetes comorbidities or complications may be rooted in fetal environment, partly independent of the presence of type 2 diabetes, which is a new way of looking at complications. I don't say that hyperglycemia is not important, not at all. I only say that it's not only hyperglycemia, there are some underlying mechanisms. Some of them have a fetal origin. So thank you so much for listening to me and for this award. Honestly, this is the biggest award and recognition I ever got. I haven't deserved it, but thanks a lot. And my sincere thanks also to my beautiful wife, Karina, who is here today for the support over many, many years. Thank you so much for that. I couldn't live without that. And there's lots of other people who are not mentioned here who have contributed over the years. So thank you, everybody, and I'll finish now.
As a mark of deepest respect and admiration for the extraordinary achievements and to express our collective gratitude for wisdom imparted to us today, may I humbly request everyone to rise and join me in offering a standing ovation to honor Professor Allan Vaag.
Not deserved, but thank you.
Thank you, everybody, and thank you, Professor Allan Vaag.